Hello, my name is Christiana Dinah, and I am a consultant ophthalmologist at London Northwest Trust, also honorary senior lecturer at Imperial College. Today I'll be talking to you about the macula, a very small but important part of the eye, and also the diseases that affect it. The function of the eye is to allow us to make sense of our surroundings. In order to do this, we need light, an eye that's organized to process that light, and also pathways to the brain that make sense of the information arriving from the eye. Today, I'll be explaining how the macula, which is a specialized part of the eye, of the retina, works, 3 common diseases that affect it, and some of the ways in which current treatments have helped to preserve sight. I hope that this talk will leave you feeling hopeful for what is to come. So the eye is a small but impactful organ. With our eyes, we process millions of pieces of information at all times and turn them into simple images very instantaneously. A good way to think about the eye is to think about it as a camera. In fact, the human eye is actually a type of eye that we call a camera type eye, and which is similar to most mammals. Jellyfish and starfish, for instance, have what we call eye spots. So they just process light and darkness and no detail. So just like a camera, the human eye cannot function without light. This light enters through your pupil, which is the round entryway surrounded by the colored part of your eye, which we call the iris. The pupil gets bigger or smaller, depending on how much light it needs to get into the eye. Then that light hits the lens. And the function of the lens is to focus the light onto your retina. So you can think of the retina as the film onto which the image is projected. The retina lines the inner surface of the back of the eye. And within the retina, there's a small specialized area of the eye called the macula. The macula is approximately 5 millimeters, which, to give you an idea of how small that is about the size of a small grain of rice. There's the macula. And at the very center of the macula is a small pit called the fovea. It has the most nerve endings of any part of the retina and is crucial for sharp, clear vision when looking straight ahead and to help us see color in our world. So things like reading text on a page, telling the difference between faces, small movements in front of you, these are some of the things that your macula helps you to do. This information is transmitted to the optic nerve, which is connected to the brain, where we make sense of what we see. Now, when you look at the retina, it is made up of specialized cells, in particular, the photoreceptor cells. The photoreceptor cells are light-sensitive cells. There are 2 types of photoreceptor cells called the rod and the cone. The rods process black and white light and help you see at night and in dim vision. The human eye has over 100 million rod cells. In contrast, the cone photoreceptors process color and how to detect fine detail. The human eye has approximately 6 million cone cells, and most of these are concentrated in the fovea. There's another structure that I think you should know about, and that's the retinal pigment epithelium. The RPE, as we call it, is the pigmented cell layer that is tightly attached to the photoreceptor cells and nourishes them. I like to think about the RPE and photoreceptors as special friends. The RPE has many important functions, but I'll just highlight 3. It helps to absorb scattered light. It helps to supply nutrients and nourishment to the photoreceptors and eliminate water. So it keeps the retina dry. And it also digests waste products produced by the photoreceptors. Another structure as well that is quite related to the photoreceptors and the RPE is the choroid. Now, the choroid is a spongy layer of blood vessels that lies under the RPE and provides oxygen and nutrients to the retina. So now you can think about this layered structure that we call the outer retina at the macula, made up of photoreceptors, RPE, and choroid. And this tight structure and this organized structure is really important for your macula to function as it should. I like to think about them as like a Roman military formation, where you have to have centurions in their position, standard bearers in their position, legionnaires in their position. This structured organization is essential to ensure detailed vision, and any disruption to this detailed structure affects the quality of the image we see. And in 2023, I don't think we can really talk about the macula and its structure without talking about optical coherence tomography. This is basically a scanning technique introduced to the eye clinic approximately 20 years ago and is now available even in many high street opticians. Using reflected light, it allows us to see the microscopic structures of the macula by taking a quick picture of the back of the eye within seconds. It's so convenient and so informative that you risk having one just by walking through by an eye clinic. It's really that easy to do. It also means even as I said, even a casual walk by the eye clinic would likely result in an OCT for all and everyone. The yellow arrows that you can see at the center points at the fovea, which I explained to you earlier, is the pit at the center of the macula. The outermost brightest white line with a larger, thicker yellow arrow is the RPE, and the red arrow points to the photoreceptor layer. So you can see that things that we used to be able to, we needed microscopes and histology to see, we can now see simply by taking a picture of your back of the eye within seconds. And it allows us to be able to understand what's happening to these cells and how any disease is impacting them. The macula is also made up of some blood vessels. So there's a couple of layers or network of blood vessels that run through it, and they lie just above the photoreceptors. These are like secure tunnels channeling blood through the retina. When a disease affects these blood vessels, they can become leaky and allow the contents of the tunnel to seep into the retina, changing the organization of the structure I described and affecting the quality of vision. In more advanced OCT scans, we can now see these blood vessels and determine how they're being impacted by any diseases. So how does the macula work? If we think of the whole retina processing information like a lawn sprinkler with water going everywhere, the macula, with the concentration of cone cells, means it processes information like an eyedropper with a lot of detail. And because of this, when the macula is disrupted, there is still vision, but there tends to be lack of detail and blurring of vision. So in summary, so far, we've talked about the eye as a camera, the retina as a thin layer that lines the inner aspect of the back of the eye. The macula is responsible for detailed vision. The photoreceptors, RPE, and choroid as special friends that are crucial to help us to interpret the images we see, and also that the macula has some blood vessels within it that can be affected by disease. So now I'm going to talk about 3 diseases that affect the macula. One that affects the RPE and photoreceptors, the other that affects blood vessels within the retina, and another that affects the structure of the macula. I'll start with the disease that affects the RPE and photoreceptors, age-related macular degeneration. It is a leading cause of sight loss, especially in those aged 65 and over. Now, whilst we don't fully understand everything about how this disease develops, we do know that the risk of developing age-related macular degeneration is increased with age over 50, with smoking, being of European descent, eating a diet high in saturated fats, and family history of age-related macular degeneration. There are 3 types. We can categorize age-related macular degeneration into 3 types: early, intermediate, and late. And just to remind you again about the normal structure of the macula with the photoreceptors, RPE, and choroid sort of lining sort of in a structured manner together. In macular degeneration, you start to get yellow deposits known as drusen, and they're deposited just under the RPE, separating it from the underlying choroid, which provides nutrients, as we explained earlier. This prevents the nutrients from getting to the photoreceptors and waste products of the photoreceptors from being carried away. The RPE and its special friend, the photoreceptors, become stressed and stop working properly. The blood vessels of the choroid also start to become thinner and shrink. These deposits make the RPE layer appear bumpy on OCT, like that. And you can see the small bumps on the outermost line, consistent with what we call drusen, and that's what we see in the clinic. And many people with early age-related degeneration do not notice any symptoms at all, although there may be some issues such as difficulty seeing in low light, colors may not seem as bright as they used to be, and there may be some difficulty with seeing things as sharply as before. Now, as things progress, these drusen, these yellow deposits, can then get larger, resulting in more damage to the RPE cells, more thinning of the photoreceptors, which you can see now look grayer and skinnier on this image, and the choroid getting even thinner. Some people with intermediate age-related macular degeneration become aware of straight lines appearing wavy, and you can imagine that could happen when you see how big these bumps are on the OCT scan. And also, they might get some blurring and some difficulties in dim lighting as well. And these are scans that can be done in your eye clinic or even in your on your high street. And there's currently no approved treatment for early or intermediate age-related macular degeneration. However, there is evidence that ARED2 supplements, which are essentially multivitamin supplements, may reduce the risk of progressing from intermediate macular degeneration to late stage by about 25%. Now, the late type of age-related macular degeneration is divided into two types: the geographic atrophy and wet age-related macular degeneration. Let's talk about geographic atrophy. Geographic atrophy is an advanced form of age-related macular degeneration. In GA, which is how we refer to geographic atrophy, the RPE and photoreceptors layers get so thin that the cells shrink, and you start to have a complete missing piece of the photoreceptor and the RPE layer in that particular area. There's a yellow arrow on your right pointing to an area where this has happened, and it's a small area, a bit away from the pit of the fovea, and that area has what we call geographic atrophy, but it's just starting. And for most people, approximately 80% of people, geographic atrophy starts away from the pit and then slowly over years moves to the center. So the vision measured by reading letters on a chart may seem very good, but the patient may complain of difficulty looking at light, difficulty reading, and doing certain activities of daily living. And autofluorescence is a test that we tend to do that helps us highlight which areas are affected by geographic atrophy. The yellow arrow there points to the fovea, which is the pit, and that's supposed to be black, but there really shouldn't be any other black areas in the retina. But you can see there, that area there is an area of geographic atrophy where the RPE and photoreceptor cells are lost, but it's away from the fovea. So the vision in this participant is very likely to be still good, but they might have some symptoms. For a long time, we've not had any treatments for geographic atrophy, and beyond counseling and support with low visual aids. But in February of this year, there was a breakthrough, and the first treatment was approved, which is called Syfovre in the United States, and currently being evaluated or considered for approval in the UK. Another treatment was recently also approved called Isovre in August of this year in America again, and there is a possibility that may one day come to the United Kingdom as well. Both treatments are delivered by injection into the eye every month or every other month, and the idea is to slow down how quickly that black area, that geographic atrophy area, grows to get to the fovea. But we still need to understand more about these treatments and who's best to treat and who will gain the most from these treatments. Wet macular degeneration is the other type of late-stage macular degeneration. And in this type of macular degeneration, it's less common than the dry form, occurs in about 20% of people with age-related macular degeneration, but just as commonly as geographic atrophy. And what happens here is that the stressed RPE and photoreceptor cells recruit other cells into the area and promote growth of unwanted leaky blood cells. And these blood vessels then cause leakage and blood to cause the photoreceptors and RPE cells to shift away from their very organized sort of formation, causing blurred vision. And the symptoms that may be noticed include blurred vision, straight lines appearing bent, known as distortion, or just general blurring. And this is an OCT scan of someone with wet macular degeneration. And you can see the RPE is bumpy, but in the very center, you've got large black areas, and there's no foveal pit. There's no pit because that's all filled with leaking fluid from the blood vessels. In 2006, NICE approved the first intravitreal anti-VEGF injection. And this treatment was designed to help cause shrinkage of those blood vessels and stop them from leaking, and therefore improve vision and get rid of the blurring. And they've worked really well. And since between 2006 and now, we've had many more similar anti-VEGF treatments approved, but with even more effectiveness, such that whilst we used to have to give treatments every month, these days, the treatments that last either every other month or every 3 months or every 4 months, depending on the eye. And this has led to a reduction in the number of people losing sight due to wet macular degeneration by at least 30%. I would like to emphasize that these treatments work to rapidly improve vision in the first 3 to 6 months. And then after that, the treatments have to continue to help maintain the vision that has been gained. So in summary, we've talked about age-related macular degeneration and that it can be divided into early, intermediate, and late macular degeneration. We've talked about a balanced diet or supplementary vitamins can reduce the risk of progressing to late macular degeneration by 25%. We've highlighted late macular degeneration can be divided into geographic atrophy or wet macular degeneration. And also, excitingly, 2 new treatments have been approved for geographic atrophy, and that the treatments that we have for wet macular degeneration have reduced loss of sight by at least 30%, with more people requiring fewer injections than they used to. The next disease I'll be highlighting is called diabetic macular edema. About 422 million people in the world now have diabetes, so it is officially a pandemic. Diabetic macular edema is the most common cause of sight loss in people with diabetes. It is a complication of diabetes, with about 1 in 15 people with diabetes developing diabetic macular edema, and it affects approximately 20 million people worldwide. However, only a small number of people from that proportion will develop severe visual loss from diabetic macular edema. Now, in the macula, the small blood vessels tunneling through the macula are created with reinforcement to make sure they don't allow any leakage, which would disorganize the neatly patched structure I mentioned earlier within the macula. Now, in diabetes, the body struggles to deliver the sugar in the bloodstream to the cells that need it for energy. So there is a high blood sugar in diabetes. And this high blood sugar levels damage the small blood vessels in the macula over time and can cause them to leak. And this leakage causes a disruption or a disorganization of the structure within the macula, causing blurred vision. You can see the image on your left, which shows an OCT scan of someone with diabetic macular edema. The outermost brightest line, which is the RPE, is straight line, no bumps. So this is unlikely to be age-related macular degeneration. But you can see there is no pit, and also the large black round circles, which indicate fluid in the retina, in the macula, causing disorganization. And there's an image on your right that describes exactly where those blobs are and shows the photoreceptors being shifted away from where they should be. And for this condition, treatment in the first instance is improving the control of diabetes and blood pressure, which helps to promote clearance of this fluid from the macula. But also, for over 4 decades now, laser treatment has been used to treat diabetic macular edema with good results. Laser treatment for diabetic macular edema is painless, is quick, 10 to 15 minutes, and is done on the sort of microscope that you would normally see when you go to the eye clinic. And we just put a lens on the eye, shine a couple of spots of red lights, and that usually helps the RPE to pump away the fluid. However, we can't use that treatment for diabetic macular edema when it affects the pit, the very center. So what we do with that is we treat with these injections that we also use for wet macular degeneration, because they've been shown to work really well as well for diabetic macular edema. There's also other injections with steroids that can also help to clear fluid in diabetic macular edema. So this is an example of a patient of ours who, on the left, you can see a picture with circles on it, and the very central circle, the small circle, is the foveal pit. And away from that, you can see an area of red, sort of a red round area with the red arrow pointing to it, and that is where there is leakage. And we applied laser to that area, and within 6 months, you can see that redness is now far away from the center and unlikely to cause problems to this patient's vision. And that's how laser works. However, this other patient has the edema at the center of the vision, and you can see that there's no pit because the fluid is there. So instead of laser, we gave them 4 injections, one every month for 4 months, and you can see the image on the right. There's now a pit in the center, and a lot of those black holes are gone. This patient will likely need treatment every 2 to 3 months to maintain that foveal pit that you can now see there. Other diseases that can cause macular edema include retinal vein occlusion and some retinal dystrophies, and you can find more information about this on the Macular Society website. So in summary, diabetes is a very common disease. Diabetic macular edema is the most common cause of sight loss in diabetes. Treatment is available with laser, intravitreal anti-VEGF, and even intravitreal steroids. And there is ongoing work to increase the time between treatments and to develop treatments that only require 1 injection or even 1 surgery to maintain the vision. But that is still in stages of research. Now, the final disease I'm going to talk about is macular hole. This is quite an interesting disease because it is quite different from the other 2 that we've spoken about. A macular hole is a small gap that opens at the center of the macula. So you can see the OCT scan that is now showing, and you can see from the yellow arrow is pointing to a gap in the middle. There's no pit, and instead we have a gap. There's actually missing, the 2 sides are not connected. And why do macular holes occur? Well, as we grow older, the jelly-like fluid that fills the back of the eye shrinks and pulls away from the retina. This is called a vitreous detachment. In some people, the vitreous is attached more firmly to the macula, and it pulls on the macula as it comes away, and this pulling can cause a macular hole. The macular hole can also be caused by trauma or by being very short-sighted. And what symptoms would you expect if you've got a macular hole? Well, blurred vision is one, distortion, and by distortion I mean when you're looking straight ahead, straight lines or straight edges appearing bent or wavy, or like they're missing a patch in the center. And how is this diagnosed? Usually using a microscope, like the one pictured there, which is the one you typically would see in an eye unit with light shining on and your clinician looking at the back of the eye. But now OCT, again, as we said, has revolutionized how we diagnose things, and that's the most common and accurate way of confirming the presence of a macular hole. And how do we treat macular holes? Well, the treatment is a vitrectomy surgery, and surgery can sound very, very scary, but vitrectomy for macular hole is quite an established surgery and safe, and now often done under local anesthetic. A vitrectomy is a type of surgery where the doctor removes the jelly-like fluid at the back of the eye and any tissue on the surface of the macula and injects a gas bubble into the back of the eye. The bubble acts as a temporary bandage that holds the edges of the macular hole together and helps your eye close the hole. Treatment works best when carried out early, so it's really important that you see an eye doctor as soon as it's offered, so that you can have the treatment if required. So again, just to summarize what we've talked about today, we've talked about the macula and its organization, including special friends, RPE, photoreceptor, and choroid. We've talked about 3 common diseases and how they affect the macula: age-related macular degeneration, diabetic macular edema, and the macular hole. And also we've talked about some of the treatments available for these diseases. I hope that this lecture has given you hope that eye research is moving forward and most eye diseases are becoming treatable, and that you found that very informative. Thank you very much.